There is a mistake families make every single day when memory starts to slip after 60. A husband repeats the same question 3 times before lunch. A wife forgets the turn she has taken to church for 15 years. A father who once handled every bill in the house suddenly loses track of passwords, appointments, and names he should know cold. And almost everyone around them reaches for the same explanation. Getting older, just aging, maybe the beginning of dementia, but sometimes that is not the first truth. Sometimes the first truth is sitting in a pill organizer on the kitchen counter. Sometimes it is in the nighttime medicine by the bed. Sometimes it is in the bladder pill, the anxiety pill, the allergy pill, or the one medication nobody ever thought to question because it came from a doctor, a pharmacy, or an open shelf at the store. And that is exactly why this conversation matters. Because not every case of memory trouble after 60 is caused by a disease that started in the brain. Sometimes memory gets worse because the brain is being chemically slowed, dulled, or overloaded. And the most dangerous part is this: the change is often gradual enough that people don't connect the dots until months have gone by. I want to be precise with you today. I'm not going to tell you every medicine on this list causes permanent dementia in every person who takes it. That would be sloppy medicine. What I am telling you is something more useful than fear. These are 9 categories of medications that can contribute to memory loss, brain fog, slowed thinking, confusion, or cognitive decline after 60, and some of them are far more common than most older adults realize. We're counting down from the ones people least expect to the one I believe hides behind more cases of medication-related memory decline than almost anyone is talking about. And stay with me for number 1, because it is not a single drug at all. It is the pattern that turns several mild medications into one serious threat. Before we start, tell me in the comments your age and how many medications you take every day. Not because I'm being nosy, because one of the fastest ways to predict hidden cognitive risk after 60 is not one diagnosis. It's the length of the medication list. Let's begin. Number 9. Statins. I'm putting statins at number 9 for a reason. Not because they are unimportant, and not because they are harmless. I'm putting them here because this is one of the most misunderstood categories on the list. Drugs like atorvastatin, simvastatin, and others are prescribed to lower cholesterol and reduce the risk of heart attack and stroke. For many people, they are doing exactly that. In other words, this is not a blanket anti-statin speech, and it should never be taken that way. But here is the part older adults deserve to know. Statin labels have included reports of memory loss and confusion, and those effects have been described as generally non-serious and reversible when the medication is adjusted or stopped under medical supervision. That matters, because if a person starts a statin and then begins to feel mentally off, slower recall, fuzzy names, a sense that they are not as sharp as usual, that experience should not be dismissed out of hand. At the same time, the broader evidence is mixed, and this is where credibility matters more than drama. A more recent narrative review on statins and cognitive health did not support a strong claim that statins commonly cause lasting cognitive decline. In fact, the literature is all over the map, with some studies finding concern signals, some finding no meaningful harm, and some suggesting possible protective associations in certain contexts. So what is the honest conclusion? Simple. Statins belong on the review list, not the panic list. If you started one and then noticed a clear change in memory, attention, or word finding, that is worth discussing with your doctor. If you have been taking one for years with no issue, that is a very different situation. The mistake is not taking the medication. The mistake is assuming any brain change after 60 must be aging and therefore not worth reviewing. That is why this category opens the countdown, because it teaches the rule that will matter through the rest of this video. A medication does not have to be bad to be the wrong fit for your brain, and the next one is the perfect example of that. Number 8. Proton pump inhibitors. This is the medicine millions of people stay on for so long that it disappears into the background of life. Omeprazole, esomeprazole, pantoprazole, the reflux pill, the heartburn pill, the one that keeps the burning out of the chest and lets dinner go down without regret. For many people, it works beautifully. That's why it stays, not for weeks, for years. And that is where the question begins, because the issue with long-term proton pump inhibitor use is not as simple as, this drug causes dementia. The evidence does not justify saying it that cleanly. What the better research supports is something more cautious and more useful. Long-term use may come with downstream problems that matter for brain health, including reduced absorption of nutrients like vitamin B12 in some patients, and older adults on prolonged therapy may deserve nutritional review. Why does that matter? Because vitamin B12 is not a decorative vitamin. Your nervous system depends on it. When B12 drops low enough, people can develop numbness, fatigue, balance trouble, brain fog, and memory changes that can start to look disturbingly similar to age-related decline. And here is the trap. A person develops reflux, gets put on a PPI, stays on it for years, gradually gets more fatigued, more foggy, more forgetful. And nobody circles back to ask the obvious question, do we still need this medication at this dose for this long? Now, to be fair, the research here is mixed. Some reviews report an association between prolonged PPI use and lower B12 or calcium status. Others do not find a clear, consistent relationship. So I would not present this as one of the strongest causal categories on the list, but I would absolutely present it as one of the most neglected review categories. Because older adults are often left on these medications indefinitely, not because someone made a fresh decision, but because the prescription never got reevaluated, and that happens all the time in medicine. The solution is not to stop it on your own. The solution is to ask better questions. Why am I still on this? Is this the lowest dose? Do I still need daily use? Has anyone checked whether long-term treatment is affecting my nutrition, especially if my memory or energy has changed? This one is lower on the countdown because the evidence is more nuanced, but the next one is much less nuanced, and it is in medicine cabinets everywhere. Number 7. Diphenhydramine and other first-generation antihistamines. This is where the countdown starts getting more dangerous, because now we're moving into a category older adults often trust, precisely because it is so familiar. Diphenhydramine. Most people know it as Benadryl, but it also hides inside many nighttime products, cold formulas, sleep aids, and PM medications. That matters because a person may think they are taking one sleep aid, one allergy pill, and one nighttime pain medicine, when in reality, they are taking the same brain-slowing ingredient from multiple angles. And in older adults, that is where trouble starts. The key word here is anticholinergic. If that sounds technical, keep it simple. Your brain relies on a chemical messenger called acetylcholine to help with attention, memory, and mental sharpness. Anticholinergic drugs block that system. In younger people, the effects may feel like drowsiness. In older adults, the same effect can look like confusion, forgetfulness, sedation, and a mind that simply does not fire the way it used to. The 2023 AGS Beers criteria specifically warns against first-generation antihistamines like diphenhydramine in older adults because of their strong anticholinergic properties, and those same criteria warn that cumulative anticholinergic exposure is associated with higher risk of falls, delirium, and dementia. That is not a small warning, and it explains a pattern I have seen over and over again. An older adult cannot sleep. They start taking something over the counter. It works. So they keep taking it. A month becomes 6 months. 6 months becomes 3 years. And somewhere in the middle, they stop feeling mentally crisp. They are more forgetful in the morning. They misplace things. They feel slowed down. They forget details of conversations that happened yesterday. And because the medicine came from a store shelf, they never think of it as a serious cognitive risk. That is the illusion. Over-the-counter does not mean brain neutral. It means easy to buy. If you are over 60 and taking diphenhydramine regularly, especially at night, that deserves a review. Not a guilt trip, a review. Look at the label on any nighttime product you use. Look at anything marketed for sleep or PM relief. If diphenhydramine is in there, do not assume it is harmless, simply because you did not need a prescription to get it. And if you think this is concerning, wait until we get to the bladder medication later on this list, because it hits the same chemical system in a way many older adults never see coming. But first, let's talk about the medication class that can calm the nervous system while quietly stealing mental clarity. Number 6. Benzodiazepines. These are the medications many people describe as a lifesaver the first time they take them. The panic softens, the muscles unclench, the mind slows down enough to sleep. Drugs like lorazepam, alprazolam, diazepam, and clonazepam can feel incredibly effective in the short term. And that is exactly why older adults can get pulled into long-term use without realizing the cognitive price they may be paying. Now, I want to be careful here. The research on benzodiazepines and permanent dementia is not as straightforward as some videos make it sound. Some expert discussions emphasize that the strongest consistent finding is not necessarily permanent dementia, but clear cognitive impairment during regular use, slower thinking, worse concentration, poorer short-term recall, more sedation, more instability. And from a practical standpoint, that is already serious enough. A deprescribing guideline for older adults states that all benzodiazepines increase the risk of cognitive impairment, delirium, falls, fractures, and motor vehicle accidents in this age group. It also cites a 5 times higher risk of memory and concentration problems. 5 times. That is not subtle. It means the person taking it may say things like, "I'm just not thinking clearly. I can't focus. I walk into a room and forget why I'm there. I feel like I'm moving through cotton. And the tragedy is that those symptoms are often blamed on anxiety, aging, bad sleep, or stress instead of the drug itself. Then there is the second trap. Because once people have taken these medications regularly for long enough, they can feel impossible to quit. Sleep becomes dependent on them. Anxiety rebounds without them. The body adapts. So people keep taking them, not because the drug is still the best option, but because stopping feels worse than continuing. That is why I need to say this clearly. If you have been taking a benzodiazepine regularly, do not stop abruptly. SAMHSA's 2025 guidance is explicit here. In older adults, abrupt discontinuation can be dangerous, and tapering must be gradual and done with professional guidance. So the right response is not fear. The right response is, how long have I been on this? How often am I taking it? Am I more forgetful, more sedated, or less steady than I used to be? And is it time to talk with my doctor about a slower, safer plan? Quick pause here. If this video is helping you connect symptoms to medication in a way nobody has explained before, tap the like button and tell me in the comments how many prescriptions you're currently taking. Because the deeper we go into this list, the more one pattern keeps showing up. The brain is rarely harmed by just one thing. It is often harmed by stacked effects. Now let's move into a drug that is still prescribed for several very different problems, even though older brains often pay a bigger price for it than people realize. Number 5. Amitriptyline. Amitriptyline is one of those medications that keeps showing up in places people don't expect. It may be prescribed for depression, but it may also show up for nerve pain, sleep trouble, migraine prevention, or chronic pain syndromes. And because it can be given in a relatively low dose, people often assume it must be gentle. That assumption is exactly what makes it risky in older adults. Amitriptyline is strongly anticholinergic. That puts it in the same broad danger family as diphenhydramine. The difference is that people tend to treat a prescription drug as more legitimate and an older antidepressant as more established, which makes them even less likely to question it. But the aging brain does not care whether a medication is old, common, or respected. It cares what that medication is doing to the chemistry of memory. The 2023 AGS Beers criteria specifically flags amitriptyline among antidepressants with strong anticholinergic activity that older adults should generally avoid. And that makes sense clinically. Because once acetylcholine is repeatedly blocked in a brain that is already more vulnerable with age, people can experience a kind of flattening of mental sharpness. Not always dramatic at first. Sometimes it starts with small things. Losing words, slower recall, trouble following a conversation when there are distractions in the room, a sense that reading takes more effort than it used to, forgetting what you meant to do halfway through doing it. The particularly deceptive part is that older adults are often put on amitriptyline for symptoms that already affect quality of life: pain, sleep, headaches, mood. So when memory gets worse, the decline gets blamed on the condition itself, not the treatment. That is how medication-related cognitive loss hides in plain sight. And when amitriptyline gets combined with other anticholinergic drugs, allergy pills, bladder medications, certain sleep aids, the concern becomes much bigger than the single pill by itself. If you take amitriptyline and you feel more foggy than you used to, especially if you are also taking any nighttime antihistamine or bladder medication, that is not something to shrug off. That is something to review. Because the next medication on this list is especially dangerous for one reason. People think of it as a modern antidepressant, and modern often gets mistaken for cognitively safe. Number 4. Paroxetine. Paroxetine is one of the most important don't miss this medications on the entire list. Why? Because it lives inside a class many people assume is broadly safer. It is an SSRI. It is used for depression and anxiety. And when older adults hear SSRI, they often assume the entire category is basically interchangeable. It isn't. Paroxetine is different in a way that matters. Among SSRIs, it stands out for stronger anticholinergic effects, which is exactly why it appears in the Beers criteria list of medications older adults should generally avoid. That means a senior can be prescribed a medication for mood or anxiety and never realize the same pill may also be pushing against one of the brain's core memory systems. And that mismatch is dangerous, because when an older person develops forgetfulness while on a medication for depression or anxiety, family members often assume the original psychiatric problem is getting worse. In reality, the medication itself may be part of what needs to be reviewed. This is one reason I tell people not to think in terms of good drugs and bad drugs. Think in terms of right fit, right age, right chemistry, wrong chemistry. A medication can be appropriate in one person and a poor choice in another. In older adults, paroxetine often lands in the second category because the anticholinergic load matters more with age. And this becomes especially important if the person is already reporting brain fog, short-term memory problems, word-finding difficulty, or a feeling that their mind is less agile than it used to be. What do I like about catching this one early? It is actionable. Because once paroxetine is identified as part of the problem, the conversation becomes much more specific. Not, why am I getting old? But, is this the right antidepressant for an older adult with cognitive concerns? That is a much better medical question. And if you think that is serious, the next one gets worse, because it is often prescribed in situations where the person taking it may not even fully understand what category of drug they are on. Number 3. Oxybutynin and other bladder antimuscarinics. This is the medication category I wish more families knew about before memory trouble began. Because bladder urgency after 60 is common, embarrassing, disruptive, and exhausting. People plan their day around bathrooms. They stop going out as much. They sleep poorly because of nighttime trips. They become afraid of accidents in public. So when a medication finally gives relief, it feels like a gift. And that is why oxybutynin can quietly stay in the routine for years. But here's the problem. Oxybutynin is another strong anticholinergic medication, and available data have linked it to impairments in memory and attention, with particular concern in older adults. That should immediately get your attention. Because now we are no longer talking about a medication that merely causes sedation in some people. We are talking about a medication class directly tied to the kinds of mental changes families often fear most. Forgetfulness, poor concentration, slowed thinking, mental dullness. And what makes this category especially cruel is that many older adults are never warned in language strong enough to stick. They are told the pill may dry the mouth, maybe cause constipation, maybe make them a bit sleepy, but they are not always told. This medicine can be hard on an aging brain, and that missing sentence changes everything. Because once someone knows that risk, they watch themselves differently. They notice whether their recall got worse after starting it. They notice whether they are more confused at night. They notice whether the benefit to the bladder is being bought at too high a cognitive price. The 2023 Beers criteria specifically flags oxybutynin, and newer review literature continues to raise concern about its cognitive effects in older adults. That is not fringe information. That is exactly the kind of information seniors should have before a medication becomes a long-term habit. If you or someone you love takes oxybutynin, this is a medication worth reviewing sooner rather than later, especially if memory has worsened over the same general period. And now we move to a category where the danger is not just memory loss. It is something even more serious in older adults with dementia-related symptoms. Number 2, antipsychotic medications used in older adults. This is where the conversation gets heavy, because drugs like quetiapine, risperidone, olanzapine, and similar medications are not small, casual, harmless tools. These are powerful brain-acting medications. Sometimes they are clearly necessary, sometimes they are being used in extremely difficult situations, and sometimes, especially in older adults with agitation, confusion, or behavioral symptoms, they are started because everyone in the room feels desperate for something to work. I understand that. But desperation is not the same as safety. The FDA warning history here exists for a reason. Reviews discussing atypical antipsychotic use in dementia-related psychosis describe a boxed warning tied to increased mortality, with relative risk estimated around 1.6 to 1.7 compared with placebo in that setting. Think about what that means. This is not simply, this medicine may make you a little groggy. This is, in a vulnerable older population, this category carries enough danger that it triggered the strongest kind of labeling warning. Now, this video is specifically about memory loss after 60, so let me connect that piece clearly. Antipsychotics can suppress and flatten brain function in ways families describe as devastating. Less engagement, less spontaneity, less responsiveness, less emotional presence, and sometimes a person who seems physically there but mentally dimmed. That distinction matters, because family members may say, the agitation is a little better, but I feel like I'm losing them. And that feeling deserves to be taken seriously. I am not telling you these medications are never appropriate. I am telling you that older adults and their families should never drift into them casually, vaguely, or indefinitely, without very clear review. Why was it started? What exact symptom are we treating? What benefit are we seeing? What cost are we accepting? Is the dose the lowest possible? Is the plan still justified? Those are the right questions. And now we come to number 1. The hidden engine behind many of the stories in this video, the pattern that takes several individually manageable medications and turns them into one much bigger cognitive threat. Number 1, cumulative anticholinergic burden and polypharmacy. This, in my view, is the real villain behind far more memory decline after 60 than most people ever realize. Not one pill, not one brand name, not one prescription. The burden, the stack, the total chemical weight of multiple medications pushing the brain in the same dangerous direction. This is what older adults almost never get warned about in a way that changes behavior. A person may be taking a nighttime antihistamine for sleep, a bladder medication for urgency, an antidepressant with anticholinergic effects, maybe something for motion sickness, itching, or pain. Each medication alone may look manageable. Each one may have been started by a different doctor, at a different time, for a different reason. And because nobody steps back to review the whole list as one system, the brain ends up absorbing the sum of all of it. That is anticholinergic burden. And the 2023 AGS Beers criteria is explicit that cumulative exposure to anticholinergic drugs is associated with increased risk of falls, delirium, and dementia. Not one pill. Cumulative exposure. That is the phrase older adults need burned into memory, because this is how medication-related decline hides. A family sees gradual forgetfulness, a little more confusion, a little less confidence, a few more repeated questions, a few more mistakes. Nobody sees a stroke, nobody sees a dramatic injury, nobody sees a single obvious cause. So everyone says the same thing. Well, maybe this is just what happens now. But sometimes it is not what happens now. Sometimes it is what happens when 5 different medications all chip away at the same memory pathway, and nobody adds up the score. That is why a medication review can be so powerful. Not glamorous, not dramatic, not expensive, just powerful. Because when the true problem is cumulative drug burden, the first step is not a heroic diagnosis. It is a full list. Every prescription, every over-the-counter product, every sleep aid, every allergy pill, every PM formula, every as-needed medication, everything. And once the full list is on the table, you can finally ask the question that should have been asked much earlier. Which of these are helping me? Which are harming me? Which are duplicating each other? Which are safe in younger adults, but not ideal after 60? And which are making my brain pay for relief somewhere else in my body? That is the conversation I wish more older adults had before memory trouble became a label they carried for the rest of their lives. Because here is the hopeful part. Not every medication-related memory problem is permanent. That matters. If a person's mental sharpness has been dulled by a drug effect, or by stacked anticholinergic burden, there may be room for improvement once the medication list is reviewed and adjusted properly. I am not promising a miracle. I am telling you something far more useful. The cause may be more reversible than people think, and that possibility alone is worth taking seriously. So let me leave you with the practical bottom line. If you are over 60, especially if you are taking several medications, and you have noticed brain fog, short-term memory lapses, slower recall, confusion, more sedation, or a decline that seemed to creep up over time, do not stop at the explanation, "I'm just getting older." That explanation may be true, but it may also be incomplete. Review your medication list, especially if it includes diphenhydramine or other nighttime antihistamines, benzodiazepines, amitriptyline, paroxetine, oxybutynin, antipsychotics, or a long list of overlapping brain-acting drugs. And please hear this part clearly. Do not stop prescription medications on your own. Do not taper benzodiazepines by yourself. Do not make sudden changes because a video scared you. Use this video the right way. Use it as a reason to ask for a proper medication review. That one appointment may do more for your brain than people realize. Now I want to hear from you. How old are you? And how many medications are you taking every day? Have you ever noticed more forgetfulness, more fog, or more confusion after starting a new prescription or even an over-the-counter sleep aid? Tell me in the comments, because when older adults compare notes, patterns show up faster. And sometimes one person's comment becomes the warning that protects another family. And if this video made you think differently about what memory loss can look like after 60, stay with me for the next one. Because medications are not the only place the body gives early warning signs. Sometimes your body signals trouble in places most people ignore completely, long before a diagnosis becomes obvious. That's what I'm covering next. Stay sharp, stay curious, and I'll see you in the next video.